what strategies do you employ to prevent intubation? How about Dr. Hawkins? Can you get started with that question, please?
Sure. Thanks, Dr. Davison. So yeah, certainly throughout the pandemic and in certain regions across the world, there have been a lot of concerns about resource utilization when it comes to COVID. And when you think about a respiratory illness, the first resource that comes to mind would be a ventilator. So we had to get savvy with our ideas for how we would prevent intubation in this very sick population. One of the first things that we went to was high flow nasal oxygen or high flow nasal cannula. Takes the air and the oxygen from the wall, puts it through a blender, and then provides a very high flow and up to 100% oxygen, humidified and warmed to the patient, and allows you to provide this high inspiratory flow rate that can also match the patient's work of inspiratory flow or inspiratory effort, and decrease their work of breathing. We didn't have much to look at as far as evidence goes, like much with COVID, but when you look at the use of high flow nasal cannula in other ARDS populations, and you look at the New England Journal study from 2015, they looked at all comers with ARDS and high flow nasal cannula with hypoxemia and not hypercapnia, and found that at 90 days, mortality was lower in the high flow oxygen group compared to standard oxygen or non-invasive ventilation. They found in the patients with moderate to severe ARDS that they were less likely to require mechanical ventilation. So with evidence that came out suggesting that there was not as much risk of aerosolization as we initially feared with high flow, we went to using that quite a bit. When we look at non-invasive ventilation, it's another strategy that we often use across the board to try to prevent intubation, and it doesn't have the best track record in ARDS. Traditionally, it works very well for your COPD patient, your cardiogenic pulmonary edema patient, but we know from the lung safe study and from other studies that we've seen that with patients that have more severe ARDS, that non-invasive ventilation actually leads to an increased mortality, and perhaps that's because we end up delaying intubation until it becomes an emergency. Perhaps it's because they oftentimes have these uncontrolled, very high tidal volumes from huge work of breathing, and perhaps we're inducing lung injury with non-invasive ventilation before we even get to mechanical ventilation. So with mild ARDS, non-invasive ventilation is probably okay, but with moderate to severe, it's probably not as effective. And I think we've learned similar things looking at other respiratory epidemics like H1N1 and MERS. Most of the observational studies, at least out of those times, showed that non-invasive ventilation did not have any good outcomes, and certainly in some patients had worse outcomes. Some of the things you have to think about, especially if we're trying to use these strategies to prevent patients from coming into the ICU, is how are we going to monitor them on other units in the hospital? Because if they take these devices off, if they take off their BiPAP, if they take off their high flow nasal cannula, we know they plummet and they desaturate very, very quickly, and it can become an emergency very quickly. So in our hospital, many of the rooms on the general medicine wards did not have windows. We had to put more windows in. We had to make sure there was enough staffing to change the nursing ratios on the floor. We had to teach the nurses and the RTs how to titrate both the flow and the FiO2. For us, we were able to fortunately utilize rapid response nurses, which was a great resource that we have, but not every place has that. It's whether a patient needs to be upgraded to the ICU on high flow nasal cannula. A lot of that is obviously a judgment call. It's a clinical decision at the bedside. What does their work of breathing look like? How fast are they breathing? There is the ROX index, which takes into account saturation, how much FiO2 they're on, and what their respiratory rate is. So there are, hard numbers. So whether you're utilizing a rapid response nurse or an index, these patients need to be reassessed every, 30 minutes to 2 hours to make sure that we are that they're not deteriorating quickly. Last, one of the strategies we used and that has been talked about, though the evidence may not necessarily be there, is awake proning, and we came to call that tummy time. We know that it works in intubated patients. The Perceiva trial taught us that And certainly there is good evidence for proning patients that are intubated, but for proning awake patients, the evidence is not as much there, but physiologically it makes sense. When somebody is supine, most of that dorsal lung is compressed by the weight of the heart, the abdominal viscera, the ventral lung, and the dorsal part of the lung gets the majority of the blood flow, whether the patient is supine or prone. So when you prone the patient, in addition to sort of taking the pressure of the mediastinum and the heart off of the lungs, you also have better VQ matching, because now that dorsal lung is able to expand and you have, better ventilation to match the increased amount of perfusion you have there. So we certainly felt like tummy time was something that was cheap to do, easy to do in patients that are awake, but again, requires resources of folks that are continually checking in on these patients, making sure that they're not sticking in one position for too long, and making sure that they are actually responding to it.